Hello everyone. We will be waiting a minute or so until everyone joins and then we'll get started. Alright, so let's get started. We are delighted to have you join us for Friday Night AI. We are very pleased to be joined here by two experts in AI and healthcare. My name is Rada Mihalcsa. I'm a professor of computer science at the University of Michigan. I'm also the director of the AI lab. And by means of background, we started the Friday Night AI about 2 years ago in an attempt to engage more closely with the community, with you, on topics of interest to all of us. I'm very pleased to have you all join tonight for a discussion on the role that AI can play in healthcare. We have witnessed over the past 2 years how the spread of a virus can result in a worldwide pandemic, and how rapid mutations of the virus can lead to periodical spikes and challenge even the most advanced healthcare systems. Hopes are now high that the pandemic is slowing down, but the question is really, what have we learned on how AI can help predict a disease next move? So tonight's discussion is around the development of a computational model that's now in use at Michigan Medicine, which can help clinicians anticipate fast-changing patient needs. The model is called MCures and was developed by a team of computer science, industrial operations and engineering, and healthcare researchers. And the model uses machine learning to predict which patients are at greatest risk of developing severe illness. Internal and external validation of MCures has shown it to be effective in predicting the progression of the disease across 12 hospital centers and patient subgroups. On tonight's discussion, I'm joined by two of the world experts in the space of AI and healthcare, Professor Jenna Wins and Professor Karandeep Singh. To introduce them briefly, Jenna Wins is an associate professor of computer science and engineering, also associate director of the AI lab, and co-director of precision health at the University of Michigan in Ann Arbor. Her primary research interests lie at the intersection of machine learning and healthcare. She received her PhD from MIT in 2014, was named to the MIT Tech Review list of Innovator Under 35 in 2017, and recently was awarded a Sloan Research Fellowship in Computer Science. We are also joined by Professor Karandeep Singh, who is an assistant professor of learning health sciences, internal medicine, urology, and information at the University of Michigan. He directs the Machine Learning for Learning Health Systems lab, and his recent work focusing on studying the implementation of machine learning algorithms within health systems. Now, before we get started, just a few logistics. Our plan is that for the first 30 minutes or so, Professor Wins and Singh will address various aspects of the use of AI in predictive healthcare. And then for the second half, you will have the opportunity to ask questions. For that, we ask that you please use the Q&A button at the bottom of the Zoom screen if you are joining via Zoom, or type your question in the comments on YouTube, and we'll get those questions here so we can address them. So with that, we can get started. I would like to acknowledge that tonight's Friday Night AI is a collaboration between Michigan AI, the Department of Learning Health Sciences, and jointly with the Ann Arbor Public Library, which is broadcasting the event on YouTube. So first, just for the audience to get to know you better, I would like to ask our panelists about their career path. So what was your career path, and how did you get interested in AI and healthcare, and what excites you about this space? Maybe Jenna, we can start with you.
Sure, great. And thank you so much, Radha, for inviting me to come and participate in this event tonight. I'm really excited to be here. So in terms of my career path and how I got interested in AI and AI in health in particular, it really started, I'd say, in undergrad. So I did an undergraduate degree in electrical engineering, and then I went on to pursue a master's and PhD at MIT in computer science. And when I was looking for a thesis advisor, I met John Guttig in CSAIL, which is the Computer Science and Artificial Intelligence Lab at MIT. And he described the work that his group was doing that was focused on machine learning for health. And specifically, he described this problem where they were developing machine learning algorithms to detect seizures and predict seizures in patients with epilepsy. And in listening to him describe the work and how, if successful, the project could really change someone's life, because you could tell them to sit down before they fell down, or you could tell them to pull over before they went off the road. And I was so struck by the potential impact that a single algorithm could have on patient lives. So I joined his group. I focused on AI and health throughout my PhD, and then I've continued working on that theme now as a faculty member here at Michigan.
It's great and very inspiring, and I know since I met you years back, I've been observing all the impact you've been having through your work. Karandeep, would you like to share your career path?
Yeah, so I think I grew up with an interest in computer science. My dad is a computer scientist. I always loved getting systems to work, things when they weren't working, just getting them to work. And so in undergrad, I started writing software. I went to medical school at the University of Michigan, did residency, did fellowship. And kind of along the way, I would always encounter things where a system just wasn't working as intended. So when I was a chief resident at UCLA, if you wanted to send a page, which we still have pagers, to more than 7 people, you needed to actually send separate sets of pages to 7 people at a time. So I reverse engineered our paging system to be able to send paging, group pages. So this was like one kind of basic example of just getting things to work. And I think in fellowship, I wanted to be able to look things up quickly. And so I reverse engineered our electronic health record to be able to respond to voice queries. So I could look things up and it would kind of, give you back lab results, things that you want to look up. And so after my fellowship, or alongside my fellowship, I did a master's in biomedical informatics at Harvard Medical School. And that's, I would say, when my interest in AI kind of really began, because it's the first time I really was introduced to kind of the use of AI in healthcare. And so what excites me is getting AI systems to actually work in supporting patient care. And when they don't work, trying to study why.
And we'll talk more about that tonight. I can see as one of the main challenges and actually deploying them to work. And that's also a great segue to my next question. I would be curious to hear, and I think will be of interest to the audience, about the main challenges in doing research in this space at the intersection of AI and healthcare. What do you think are the main challenges? Jenna, maybe we can go back to you.
Yeah, I'm happy to jump in. There are so many. I think the technical challenges in AI and health are really broad because there's so many different types of data, from clinical notes to imaging and interesting tasks. So you might want to estimate who's most likely to benefit from a treatment, or you might want to estimate the progression of a disease or likelihood of deterioration. And then beyond these technical challenges, you also end up falling at the intersection of 2 fields, right? So it's AI and health. And that means that you have to get good at speaking 2 different languages so that you can communicate with the experts in AI and communicate with the experts in healthcare. But the fact that it's interdisciplinary is also what makes the work a lot of fun. And I know that there's a whole host of deployment and implementation challenges too, but I'll let Karandeep speak to those.
Yeah, so I think, one thing I've seen is that over the past kind of 5-10 years, if you look at this clinical literature, these are like the medical journals that doctors read. There is just an abundance of papers describing this risk tool to predict this, that risk tool to predict that. But when you actually look at, is anyone actually using any of those tools? The answer for 99.9% of those things that are published is no, no one's actually using it. And so I think I've been really interested in what is preventing us from actually getting from something that works, supposedly, on paper, to actually being used to drive some kind of a decision, or even just support basic decision making that may not even be a medical decision, but might be, what room can we safely get someone to from the ER if we have to make a decision around, can they go to this floor versus that floor based on their medical needs? So even streamlining, just operational processes in the health system, there's so little of it that we actually do in that space compared to what's published in kind of the journals that clinicians are reading.
And Jenna, you pointed out to the challenges and both benefits on this interdisciplinary research, also deployment being a major challenge. I'm guessing also major events can be a major challenge. So zooming in on the past 2 years, if we look specifically at the COVID pandemic, can you speak about some of the challenges that you face in the research you do with respect to the COVID pandemic? Maybe we can start with you, Karandeep.
Yeah, so I think if you go back to 2020 in March, when we were looking at, kind of what was unfolding as the first surge of COVID was happening. I mean, we were in this remarkable space where every day we'd get an update, and we had, I think on March 8th, we had 1 patient with COVID, and then it was 2, and then it was 4, and then it was 8. And it was just this, pretty scary doubling, to the point where I think the forecast at that point was that if nothing changed, that, we might have 3,000 patients needing hospital beds, and we only actually had 800 adult beds available. Even as that first surge kind of petered out, and other surges have happened, our health system, I think not just at Michigan, but across the country, has been kind of bursting at the seams. We've had 100 patients at various points for the span of several weeks in the hospital with COVID, where ordinarily those beds would be open to other kinds of things. So, I mean, a lot of the capacity issues that I think we had even before COVID really came to a head during COVID. And so I think during the first surge, I think the biggest question that I think we faced was, do we need to open a field hospital? And if we open a field hospital, who goes there? And I think that's kind of where a lot of the work that Jenna is doing arose, was this real worry and concern in March of 2020. What does the future look like a month from now if we have a field hospital with 500 beds, where we need to make decisions, where we can't really adequately spend time with people to make a decision around who can safely go to that hospital or to the field hospital versus not? So I don't know, Jenna, if you can speak to that a little bit, kind of around how that conversation, I mean, you remember that was unfolding, where we were meeting pretty frequently to talk about this.
Yeah, I do remember back to March 2020, and specifically getting an email that had been sent to my group requesting input on, can we build a model? How do we build a model? And we went from kind of the concept, which was in March, to this really kind of fast-paced timeline because of the doubling that Karandeep was talking about. So hospital leadership was really worried about running out of resources, and had anticipated that we would need to set up a field hospital, and was expecting kind of things to peak around mid-April, which really gave us a month at best to develop a model. So in the early days of MCures, it was a lot of meetings between myself and students in my research group, that were kind of working around the clock to build tools that could be useful in this setting. And we were working with hospital leadership and then a number of clinicians, even just to define, okay, what's the outcome of interest? What are we trying to predict? And nailing that down did take a lot of conversations and back and forth, and we learned from each other. And I think that's what ultimately led to us meeting that timeline, that really quick timeline.
And I can see how that was very stressful, and trying to bring all the knowledge from different groups together, quickly communicated, what you mentioned previously, communicating across different expertise. And I understand also from what you were saying that it wasn't only exclusively COVID, it also other diseases being put on hold, which had other implications. So you developed the MCures model to predict which patients are at greatest risk to develop severe illness. Can you share more about this model? What is it? How you mentioned briefly, how did you come up the time back in 2020? If you can also share more about who worked on developing this model.
Yeah, so we had a few students in my group kind of leading the project. So Fahad, Cameron, Shengpu Tang, and Erkin Otlis, in addition to other students in my group as well, chipping in whenever they could. And a team of clinicians as well. So I think we had, in the end, input from at least 20 different clinicians when building the model, including Karen Deep. And early on, we had to just kind of have conversations to scope the problem in the clinical task. So what is it that we're trying to predict? Let's get on the same page with respect to that first. And then we also had the challenge of, well, this was very early on in the pandemic, like the rest of the world, we didn't know much about COVID-19. We didn't know what the risk factors were. And we didn't have a lot of data, right? So even though we were seeing this doubling of cases and this exponential growth, when it came to training data, right? So when we talk about learning a model or training an algorithm, you need data. Typically, you need a lot of data. And we had to keep all of the data that we had on patients with COVID-19 aside for validation and testing, right? How well does this model actually work? So we turned to a different population of patients to actually develop the model. So the model was not developed on people with COVID-19. It was developed on patients with acute respiratory failure who need oxygen, supplemental oxygen when they're admitted to the hospital. And again, that was a call that was made by a clinician on the team who had the insight that these populations might be similar enough that we could learn something from analyzing data on hundreds of thousands or tens of thousands of patients with respiratory failure. And then what we did was an approach that we have used frequently in the past in other work, looking at other disease, which is taking data from the electronic health record. So your electronic health record has everything from lab results to medications to procedures and comorbidities to vital sign measurements. So we can take all these data into a model and then learn patterns. So learn to detect who's most likely to develop severe illness. Having that experience, I think, was so crucial in meeting the timeline that we were given. And not just that experience, but also just the infrastructure that was in place at Michigan to do this sort of analysis. If we had to start from scratch in terms of how do we even get data out of the EHR, there's no way we would have been able to make that that timeline that we were initially given. Yeah, so Karandeep, what am I forgetting?
Yeah, no, I think one mistake a lot of people made around this time was they tried to build models just with COVID-19 patients. And even though there were so many cases of COVID-19 happening across the US, no one center really had enough COVID-19 patients and enough long-term follow-up where they could reliably predict anything. And so I think, there was this great systematic review looking at all the different, models out there for, predicting various outcomes in COVID-19. And the substantial majority of those models, right, were considered very low quality because they were single center built just on COVID-19 patients. And, if you've got 400 patients, that's not really enough patients to build a robust model with a lot of different predictors. So I think one decision that was made that was really smart decision was let's include all these other patients, which means we can look at a lot more factors reliably to try to predict it. But then the other conversation I remember having was, okay, so we've got all of these factors that might be important predictors, but if we actually want to get this thing running in the electronic health record, what are our limitations? And I think there was something like, you need to come up with 25 variables or less. So I remember, even after we had this kind of extensive process of like all these things might be useful. There was this narrowing down because at the end of the day, we were very pragmatic. If this is a really amazing model and it's in a paper and no one's using it, what's the point? And so I think that's where that conversation happened simultaneously. And so that is what allowed it to not only, I think, get studied in the way that Jenna did it, but also to be implemented so it's running in our electronic health record at Michigan Medicine today.
Yeah, it was necessary, I think, too. So the model itself makes predictions every 4 hours for every patient in the hospital. So you get these predictions, these outputs of the probability of deterioration or the probability of developing severe illness. And those predictions are based off 9 variables at the end of the day. So we started with over 2,000. Actually, we started with over 10,000. And then like Karandeep said, we narrowed it down. And here it was pragmatic. It was out of necessity because, again, we didn't have, years to prospectively validate and check how well it worked and run it in the background and measure the robustness. So we wanted to make sure that we were picking variables that ultimately would be more robust to changes, right, in the patient populations and in the workflows, and work well not just at Michigan, but at other hospitals as well.
Well, thank you. This is really fascinating to learn about how you put it all together. And your point is really taking us to the next question. Understand that the model has been validated across multiple hospital centers. How did you coordinate? I understand there are more than 12 hospital centers. I can see how each one has its own infrastructure, its own way of doing things. How did you coordinate with so many centers?
Yeah, so that was a really important piece of the puzzle. So we knew that we had to externally validate the model, right? We wanted to make the model open source, make it available to other institutions, and we have, but we couldn't do that responsibly without having first made sure that it worked at other hospitals, since it was developed on only data from Michigan Medicine. So typically, what we would do when we've done this in the past is we would start a long process of setting up data use agreements and essentially onboarding researchers here to external healthcare systems so that they can access the data, access the compute infrastructure. When I've done this in the past, it has taken months, if not longer. It has sometimes required a TB test where I've had to get on a plane, fly there so that they could read the TB test, even though the hospital was in a different state, I would never be there. There are a lot of steps or processes in place to get access to patient data, which makes perfect sense because we need to protect patient privacy, but we didn't have the time to go through those steps. So we didn't request the data. We didn't access any patient data ourselves. Instead, what we did, so instead of going to an external hospital like Massachusetts General Hospital in Boston and saying, give us your data, we gave them our code. So we shared our code with people at each of the different hospital centers and then worked with them really closely to run that code and interpret the results. And in the end, that saved us a ton of time. I think not just because we were able to avoid the data use agreement and the onboarding process, but we also avoided all the pitfalls that we would have made from working with someone else's data, right? Because we were working with experts on the ground at each of the institutions, they already know all of the intricacies and nuances and issues with their data and are able to address them. And we didn't have to repeat those mistakes. So in the end, I think that also saved us a ton of time.
That seems like a great lesson learned also for future work. Maybe thanks to the time pressure, you found a different solution. And it could be something that may be applicable for other models as well. So in terms of, so this was used for validation, for deployment. It was deployed at University of, like at the Michigan hospitals, right? Karandeep, could you perhaps comment on some of the challenges you ran? You mentioned previously that that's one of the main challenges in this space with deployment.
Yeah, so I think one challenge that I think Jenna's group was able to overcome, but I think is not as easily overcome by most research groups, is the simple act of getting the model packaged up in a way that the electronic health record understands. So that was a non-trivial step. I think Erkin, for example, was one of her students that had a lot of experience with the electronic health record and was able to kind of carry that out. So that was one of the things, that the electronic health record that we use has a very specific structure or format that expects models to be in. So if we actually want the model running in that format, we've got to do the work of translating that model into a structure that the electronic health record understands. Once it's there, I think there's still the work of figuring out, how do we actually use it? What do we do with the result of it? Should we be using it to send alerts? Should we be using it to prioritize different workflow? And I think we had learned from some of the earlier work we had done with sepsis that we may not want to start with alerts. Alerts are can be a really helpful way to flag patients in need of help, but when you have too many alerts or false positives, then they can cause alert fatigue and be really problematic. So the way we're actually using it today is we have a rapid response team in the hospital. This is a set of ICU nurses who are trained to. Here. Is this what you want? What are you looking for? Oh, sorry. We have a rapid response teams or ICU nurses who are trained to respond to emergencies where someone's not looking good and the nurses identify that they need some help. And so they get called, they come to the bedside. Well, when they're not getting called, they're not just sitting around. They're trying to figure out, who are patients most likely to end up in the ICU, who they can check in on proactively. And so today, they're using the MCures model. Every morning they kind of print out a list of high-risk patients, and they spend their day kind of checking in on those patients. So that's not exactly the use case in which we tested it. The original work was intended around COVID, but there's a much bigger problem around ICU capacity and needing to prioritize. And so this, I think, gets at one of the key issues that comes up all the time in model deployment. Sometimes you develop a model for one purpose, and when you actually want to use it, it's a slightly different purpose. And so a lot of times there's a little bit of work of translation and understanding, how well does this model tested for one purpose work in that new context. So I think that's where we are today with that. And so, but I think, we are looking at, is this going to be something useful for alerting? Are there things that we can do? Are there special populations where we might want to generate alerts, like patients with bone marrow transplants or patients who are immediately post-surgery, where they're kind of in this holding area where we might want additional kind of eyes on them? So, that's kind of the things we're thinking through.
And I would just add to that, because I've learned this from others, and I think it's really true, at least it resonates with me and my experiences, is that deployment is really the wrong term, because deployment gives you the impression that you're like parachuting the model down into the hospital and letting it go. And like just hearing Karen Deep speak, you get a sense of how much work is necessary after you have the model, right? After you've validated a model. So it's really about integration of the model with clinical workflows, and thinking through how that's going to affect clinical workflows, patient outcomes, and decision-making throughout the hospital.
And I see all these factors playing a role, all the different contexts that currently you are pointing to, and you validated across different hospitals. I'm also wondering, thinking of different illnesses. So if you were to adapt a model like this to another illness, what would it take?
Yeah, so I think that, a lot of the work had been inspired by previous work that we've done with previous illnesses, right? So trying to, for example, predict which patients are going to develop infections during their hospital stay. So healthcare associated infections, it's a different outcome, but it's one that my research group had a lot of experience with and was able to leverage when building this model. Now we're looking at again, taking some of the lessons we've learned and applying them to outcomes like sepsis. And as Karen Deep mentioned, we're already using the model in sort of an off-label way in non-COVID-19 or patients without COVID-19 in the ICU. So I think that there are aspects of the kind of model building pipeline that can be easily adapted to other outcomes, but it's still going to take work because you need to have those conversations with stakeholders, with clinicians to understand what's the outcome, what's the patient population, what's the right way to evaluate this. So it's not as simple as just hitting run again on a Python script.
And I can see how, so you're talking about how you could adapt the model you have to different illness. But one big question that I often wonder is, what did we learn from the way we approached the last 2 years? And I'm generally more optimistic, but I'm hearing people saying that it's not a matter of if, but when will the next pandemic happen. So with respect to how we approach a problem like this, what will we do differently at that time than we've done it this time? Karandeep, do you want to start?
Yeah, I think, this is a tough question because I think a lot of the things that really, really, truly helped were things that were not AI. They were things like vaccinations, not vaccines, right? But vaccinations, and figuring out how do you turn vaccines that are developed to being able to get this out to a broad population. It's about shifting requirements, thinking about, when is spread starting to happen based on wastewater data, other data, that we want to be more careful about masking. When can we, downgrade and say that masking, may not be needed in all settings in our society. So I think that, what we've learned is that if we learn one thing, I think it's that we have to be cautious and we have to learn how to be nimble. We went from lockdown in 2020 to, things kind of coming back to normal, only to be hit by another wave of COVID. So realizing that you can't go from nothing to everything, but we've got to figure out when things are starting to happen that we have to be able to kind of shift as a society, and react to what's happening on the ground. And I think the other thing that really has taught me is exponential growth looks like the way we saw it in March, except it can happen on a lot of different timescales. In March, it was happening every day, things were doubling. But we've seen this with other waves where, it looks like things are fine, things are fine, things are fine. And then suddenly things are not fine. And it's not that suddenly things became not fine, it's that it was a slow exponential growth. But, by the time it really was brought to the attention of everyone, our hospital had 100 patients with COVID for, weeks on end. And so I think that's what has been the main lesson to me, is thinking about, reacting as a society to these kinds of things and being nimble in terms of taking seriously before they get to the extremists. But I think the other thing that we figured out is we can't build any more. Of course, we're going to build more hospital beds. We're building them right now, but we can't build an infinite supply of hospital beds. So we've really got to figure out capacity issues. How can we use AI and tools like AI to really make absolute, ideal use of the capacity that we do have?
Jenna, did you want to add anything to it?
Yeah, so I think a lot of what Karen Deep said resonates with me. I think one of the biggest lessons broadly was around how important communication of guidelines, clear communication of guidelines is. But from an AI perspective, I think some of the big takeaways were around a lack of infrastructure and how important that infrastructure is with respect to data sharing, code sharing. Many hospitals still don't have the capabilities or the people even to run the type of code that we developed. So that investment, hopefully we've learned from this, and that investment will happen or is happening. Because I think it's really important going forward for us to be ready for the next pandemic or even the next wave.
Yes, and that's, I also think that it's useful to think from all perspectives. I mean, we are talking here about healthcare, but also policy making, infrastructure, and just to be more ready, hoping that it will not happen, of course. So with that, we are getting to my final question. And as I'm going to ask our panelists my last question, I'd like to encourage the audience to ask your questions. I see some questions are already coming in. So if you are on the Zoom webinar, please type your question in the Q&A. If you are on YouTube, you can type your question in the comments and it will pass along to us. So my final question is, what are some of the ethical concerns associated with development? And I know, Jenna, you said you don't like deployment, but let's use that word until I think of a better one. Development and deployment of such AI tools. And if there are ethical concerns, how can we counteract them?
So definitely.
Jenna, did you want to start?
Right, go ahead, Karen D.
Yeah, I can go first. So I think it was your mentor, John Guttag, right? And I think he had a recent paper talking about framing the different types of bias that can enter our systems, kind of all the way upstream from historical bias in society to like representation bias, all the way down to kind of aggregation bias, evaluation bias, deployment bias. And so example of representation biases, that our patient population at Michigan Medicine is not as diverse as a lot of other populations around the country. So if we build and test models only in our health system, we're going to come away with a false impression that maybe things work better than they actually do, just because we haven't, when you have a more homogeneous population, you have less edge cases for the model to look at, where it can learn and you can see how well it does under a different set of circumstances. In terms of deployment bias, we have to really worry that, or is what we're going to do with the result of the model, smart and fair. So an example of this is we've talked a little bit about deploying a model that can predict, who's not going to show up to your clinic appointment, a no-show model. And some centers around the country have used this model to basically double book patients. The idea being, if you've got two patients who aren't likely to show up to the appointment, you double book them. That way, you are efficient. But if they both show up, what happens is, why were those people predicted to be not showing up? It's usually because they had a really complex social situation. And so now what happens is you have two people showing up to clinic at the same time who actually need more of your time, but you actually can systematically devote less of your time to those two people. And so I think when we deploy things, we always have to think about, in what ways or what we is what we're going to do potentially going to be not fair, or introduce, not generalizable across important subgroups of our population. So these are things we can, to some extent, try to study in our data, but not entirely, because if you don't have a diverse population to begin with, you can't fully appreciate and understand, the extent to which this can be a problem. Which is why I think, Jenna's work in looking at this tool across so many different centers was really crucial to figuring out, is it learning something about our practice patterns and patient population here at Michigan Medicine, or something kind of more broadly generalizable that works across health settings, different geography, different demographics.
And I like how all these are brought together, the validation not only for the purpose of validating the model, but also understanding where it fails and how it fails, and eventually learning on how to counteract that, to your point of even different hospitals having different populations. And so we are now at the point of getting questions from the audience. Again, I'll encourage you to please type your questions. One question is going back to the beginning of our conversation. You mentioned that in order to train the initial model for COVID, you train on a more general data set. At that time, it was for a practical reason, there was no enough COVID data. How did you eventually correlate the model to COVID?
Yeah, so we trained the model on patients with acute respiratory failure, and then we validated the model and performed model selection and feature selection on patients with COVID-19, a smaller set of patients with COVID-19. And then we tested the algorithm and reported results on a population of patients with COVID-19 at Michigan Medicine and 12 other hospital centers. So that's how we eventually concluded that the model worked well at predicting severe illness, specifically in a population with COVID-19, even though it was trained on a population on data that was collected prior to the pandemic, so prior to 2020.
And as a follow-up question to that, my own question, we've seen different variants of COVID. So how do you continuously validate your model?
It's a great question, and something that we were really concerned about, because when we were starting to evaluate the algorithm externally, it was fall of 2020, where we saw a very different patient population in the hospital with COVID-19. So early on in the pandemic, the population, patients were much older, and they got younger as the pandemic continued. And we were concerned that since we had validated, kind of done the model selection based on data collected early on, that we had overfit to older adults and detected patterns that were just present there. So one of the things that we did was, in addition to validating the model at 12 different hospital centers, we validated across different demographic subgroups, so different age groups, different genders, different races, different ethnicities, in addition to different waves. So we looked at how the model did over the course of the entire year, from March 2020 to March 2021 in quarters. And what was really interesting was there was a fair bit of variability among the different hospital centers early on in the pandemic in terms of the performance of the model. And then around kind of the last quarter of the period of evaluation, everything leveled off. Everything became very consistent in terms of its performance. And I think that is due in part to consistency in hospital workflows and treatments and practice around treating COVID-19 more than shifts in population. But Karandeep, if you have thoughts on that.
I mean, I think one thing that was interesting in the first wave was even the meaning of ICU totally changed. So for example, we opened a respiratory ICU and it was a hybrid floor ICU. So you could get admitted there if you had COVID-19. And if you needed to go to the ICU, they just converted your status to ICU and you never moved. So, that whole concept of a floor bed that could turn into an ICU is, not how we typically manage people, but simply to prevent the spread of, COVID-19 beyond patients who already had come in with COVID-19 and try to isolate them in kind of one area, the whole meaning of what is considered to be an ICU change. And so normally if you're building a deterioration model, you would say, when did they move to the ICU? But in this case, we had to look at when did their status change? When did anything happen that suggested that the ICU was an inevitable setting, like they got started on medication? So I think also, we had to think a lot about what was happening in that first wave that was really different than how, care had been kind of delivered prior to that.
And just as a brief follow-up to that, there is another question asking more specifics about how you determine if a model is successful, and specifically how you determine if you should be making improvements, and possibly, that's my add-on, what kind of improvements? So
thanks, Sean, for that question. He's my recent graduate PhD student, so I think he's trying to plant questions for me. But so I think, at some point you have to make a decision, do we use it or not? And so I think successful is based on whether we think it's good enough to use. That to some degree depends on what you're going to do with it. And if you're going to use it to generate alerts, then I think you have to have this discussion around trade-off of, how many alerts are you willing to tolerate for every true alert that suggests a problem, and then make a decision around, can the model deliver that for you or not? If you're using it to prioritize care, the question is, if we prioritize care based on this model versus how we're doing it right now, does the model identify patients for you that you otherwise wouldn't have seen had you not used this model for prioritization? But it is not an easy question to answer. And one thing that I think we're really in the early stages of is the ability to do trials where we have some patients with model-driven care or model-supported care, some patients without, and being able to compare. Because if you can imagine, the infrastructure to integrate and run these models into clinical workflows is tough. The infrastructure to deliver a trial on top of that is even tougher. And so I think we're still maturing as health systems to be able to do those kinds of studies to figure out not only does the model work, but when you use the model to drive a workflow, are you actually saving lives? What's actually happening on the ground?
And you mentioned infrastructure, and there is a question around that. What type of infrastructure would be required to run the code you develop? Or maybe even more broadly, if you have a model, what infrastructure is needed to run it?
Yeah, so I can talk about this more broadly, and then Karandeep, maybe you can go into some of the details. First, you need an electronic health record, right? Because you need to be able to collect data. And Karandeep laughed there, but 10 years ago, a very small fraction of hospitals in the US actually had an electronic health record. So we've made great strides since then. So you need an EHR, and then you also need ways to pull data from the electronic health record so that you can apply a model in real time, right? So this isn't the type of model that runs in I don't know, Firefox, where you go in and you enter in each of the patient's vital sign measurements and it spits out a risk score, this is really meant to be integrated into the EHR so that it's automatically running in the background so that a clinician doesn't even have to think about it. So to that end, we have invested here at Michigan in infrastructure tied to the electronic health record that allows us to run these sorts of models in the cloud. And Karen, do you want to say more?
Yeah, I'll just say, when Ebola was taking place in West Africa and that epidemic was happening, there was a series of questions that the CDC recommended screening every patient for in the US. And there was no push button thing that you could press that would deploy something as basic as a simple questionnaire across every health system in the US. So when it comes to running models, I mean, just imagine we don't even have a way to do that. How can we possibly run a model? So the infrastructure that required, ends up being very, very specific to which vendor you're using for your electronic health record, what setup do you have, and you would think that there would be standards that would solve these kinds of things, but the issue is that the standards are not widely adopted. And like a key standard here is there's a standard called the Predictive Modeling Markup Language, or PMML. And this MCures could conceivably be, packaged as PMML, but PMML is not, doesn't have great support, and you'd have to do a lot of hand engineering to get MCures to run in PMML. So the infrastructure that we have allows us to run models written in Python. They run in a secure cloud environment that is administered by the electronic health record vendor, links up to live streams of patient data, and then returns results that get live stored into a specific area in the patient's electronic health record. So I think that's kind of what we have here. But if you had a different electronic health record vendor, you might have to go to a very different type of infrastructure, because that infrastructure isn't standardized, just in the same way that modeling representation frameworks like predictive modeling markup language aren't standardly adopted across electronic health records.
And then beyond IT infrastructure, I think you also need the people. You need resources in terms of people who will run the code, check the model, evaluate things. So that's a specific skill set and expertise that's required.
And I think people and processes. So I think, in July of 2018, we had established a clinical AI governing committee at Michigan Medicine. And having governance basically means that when something like this needs to take place, there is a process that we can follow to actually get buy-in from the organization to actually get something like this running, to be able to use resources and folks in the health system who have the skills to build stuff, to evaluate stuff, to essentially be doing this as part of healthcare delivery. So I think people is important, but also the processes, governance, which is, I think, being increasingly recognized, but I think has been one of the reasons we've been able to take stuff, is because we have a process we can follow, where at the end of the day, that process often ends in, yes, we'll get this model running, and so we can test it.
That's a great point too. I'm thinking that that's one thing that possibly we could learn now to be applicable to in other times. Again, not thinking of a future pandemic, but having a process in place probably would make a big difference. So we have another question, again, going back to the earlier part of our conversation. Jenna, you mentioned there were thousands of variables that you considered at the beginning, but then eventually you narrowed those down to just a handful. So there is a question on what variables did you decide on analyzing out of that superset?
Yeah, that's a great question. And I should mention, I don't think we've mentioned this yet, but all of this work was published in the British Medical Journal and is available online. So you can download the paper, you can download the code. And in the paper, we talk about this hybrid approach to feature selection. So typically we think about a data-driven feature selection where you use some filter method and a wrapper method. We did do that in addition to having clinicians sit down and go through this smaller set of variables that we had identified. And this was really critical because in the process, they identified this one lab that was measuring hematocrit. And Kendra, you can correct me if I'm wrong here, but I think hematocrit is a measure of the proportion of red blood cells in your blood. And what was weird about this particular variable it wasn't the particular result, like hematocrit being high or low, that was coming back as being important. It was the fact that it was measured using arterial blood gas. And the clinicians were really puzzled about why this particular variable would be important. It didn't make sense that like measuring it this way would be important and not measuring it other ways. And with a little or a lot of digging, we learned that this particular lab is measured consistently using arterial blood gas in a specific location in the hospital. And this was, in fact, a location where the hospital had set up a regional infectious containment unit, a RICU. And that's where we were sending a lot of the very sick patients early on in the pandemic. So the model was picking up on a correlation, but it wasn't a robust correlation, meaning that we closed down the RICU like a month later, or a couple of months later. And that variable, if we had kept it in the model, wouldn't have had any information later on during the fall or the winter in the pandemic. So it was kind of scrutinizing each of the variables with clinician eyeballs that helped us reduce the set, in addition to the standard kind of data-driven approach. So that was this hybrid. We had this redundancy or backup that could help us weed out the variables that might not stand the test of time.
And that's very interesting to hear how you go through and what are some other challenges, like confounds are always a challenge.
Yep.
So one final question that we can take, it's on the issue that you brought up on interoperability between electronic health records. How is this affecting the response of the model?
So Jenna can speak to this, but I think in the external validation you did, every other single center, I think, had this same electronic health record as us in terms of the vendor they use. So I think, although the configurations are not identical, there are some still differences between, configurations. I don't think we were in a position to like fully evaluate this because we, by and large, have similar configuration as the other centers we looked at least on the electronic health record side.
All right. So with that, thank you very much to the panelists for joining us tonight. And even more so, thank you for all the important work you do and understand working around the clock during time of need and really having an impact on people. We thank also the audience for being here, asking excellent questions, and also thank you to Aura Bunescu for all her help, and to the Ann Arbor District Library for hosting us. And we look forward to seeing you at a future Friday Night AI. Enjoy your Friday evening. Bye.
Thanks.